Hello and welcome to Talk of Hope, a podcast for people affected by lung cancer. I'm Rachel Avery.
And I'm Mandy Lucas.
Each episode we'll hear from people with different experiences of lung cancer, as well as healthcare professionals who will share what's going on to improve the diagnosis and treatment of this disease.
And as someone who's had lung cancer, I know exactly how terrifying it can be. But amongst all that fear and anxiety, there is also hope. And that's what we're choosing to focus on here.
Now, Mandy, were you aware, because I certainly wasn't, that 40% of people with lung cancer develop pleural effusions or fluid around the lung?
I wasn't. I think it didn't happen to me, so I wasn't aware. But no, I don't think you hear very much about it. So I'm really, really interested to hear all about this.
Because it can have a really tough, be a tough side effect for people to deal with, because that build-up of fluid can make it quite difficult to breathe. When it happens, the fluid is usually drained, but quite often it comes back, meaning people get breathless again, or may even end up coming into hospital as an emergency. So joining us today is Dr Eleanor Mishra, a consultant respiratory physician and pleural lead at Norfolk and Norwich University Hospital. Dr Mishra is also the lead researcher on a new project called the REPEAT study, which can predict how quickly fluid will return and help doctors manage patients appropriately. Welcome, Dr Mishra.
Good evening, and thank you for inviting me. It's great to be here this evening.
No, thank you for joining us. As Mandy and I were saying there in the introduction, we were quite blown away when we heard about your research, largely because of the staggering number of people that are affected by pleural effusion. Can you start just by kind of giving us a bit of an overview, an introduction as to what pleural effusion is and how it impacts on people with lung cancer?
So the lung is like a balloon inside the box of the chest wall. And usually that balloon is blown up right against the chest wall. But in some people, fluid can build up in between that space between the lung and the chest wall, or between that balloon and the box. And that squashes the lung down, pushes down on the diaphragm, and makes them feel breathless. And unfortunately, in people who've got lung cancer, it's often due to spread of the cancer out of the lung to around the outside of the lung.
Right, and I was literally going to say, my next question was what causes it?
So as cancer spreads out of the lung, it grows in different places, and as it grows, it tries to stimulate the growth of new blood vessels and so that it can get oxygen and nutrients to grow further. But because they aren't normal blood vessels, they're leaky, and that means that serum leaks out of the bloodstream, and that's what causes the fluid to occur.
That's interesting. I wouldn't ever have known that, obviously, but I would have thought it was something to do with infection, so that's really, really interesting. Amazing how much fluid it can produce then.
Yes, it can be litres of fluid, and people are often shocked when we drain it off and show them how much fluid we've drained off. They just didn't believe that there could be that much fluid around their lungs.
And that's all serum from blood from these new badly formed blood vessels from the tumour.
That's right. That's how it forms.
Incredible.
The only thing I can kind of draw any comparison with from my own personal experience, when I was pregnant, one of my babies had a condition that needed fixing after he was born, but that caused a lot of build-up of fluid, and I needed an amniocentesis, because I think with pleural effusion you need a thoracentesis. Is that correct?
That's right. That's the name we give to the procedure of draining the fluid off from around the lung. So the fluid around the lung causes a lot of symptoms: breathlessness, cough, and chest discomfort, and that's actually really disabling. It stops people doing the activities that they want to do, such as socialising and exercising. And so we drain the fluid off to make them feel better and get back to normal.
How is the fluid then drained?
So to start with, we normally do, as you said, a thoracocentesis, and that just means putting a small drain in and draining up to 1.5 litres of fluid off over about 10 or 15 minutes. So we do it with local anaesthetic to make sure that it's comfortable, and it does potentially have risks. So there is a small risk of bleeding, a small risk of infection, but generally it's a simple procedure that people tolerate well, and they do find it's really beneficial. The problem is that often the benefit doesn't last for very long, and that's where our research comes in.
And that's what we were saying about, one of the main side effects is this, it causes kind of breathlessness. And as you said just then, that has a real severe impact on a person's life. I mean, we talk a lot on this podcast about the new treatments and how people are living really well, but part of the reality, we don't want to be naive about a lung cancer diagnosis, but it can have quite severe side effects. And this is one of them.
That's right. And what people really want when they're living with lung cancer is to have the best quality of life for the time that they've got left. And this treatment is really about making sure that we do improve their quality of life and enable them to do the things that they want to do.
So that leads us onto your really important research then, actually. If we're talking, say like nearly 49,000 people are diagnosed every year and 40% of them are going to go on and develop pleural effusion. We're talking huge numbers of people. So this piece of research is going to make a difference to hopefully a large number of people living with lung cancer. Tell us a little bit about the repeat study and what you're looking to achieve with it.
So the reason for doing the study is that when we drain off the fluid initially, we know that it's going to come back at some point. But before the study, we couldn't predict how quickly it would come back. Usually when it comes back, we offer the patients something definitive to stop the fluid coming back recurrently, such as a permanent chest drain or to come into hospital to have it dealt with. But in some patients, the fluid would come back very quickly, they'd get really breathless, and they'd end up coming into hospital as an emergency, perhaps having inappropriate procedures, and we really wanted to help people avoid that. And we also knew that in some people, the fluid would come back very slowly, and they might have unnecessary procedures or turn up for diagnostic procedures and have them cancelled because there wasn't any fluid there. So the idea of the repeat study was to develop a way to predict how quickly the fluid would come back in individual people so that we could make a plan and deal with it better.
You said there about one of the current solutions is a permanent chest drain. I mean, what's the implication of that?
So that's a drain that we call an indwelling pleural catheter, and it's a small silicone tube that's tunneled under the skin, and it's put in as a day case procedure. It takes about 20 minutes to put in, and people go home with this tube in. It's usually curled round with a dressing on, so they're not attached to a drain all the time. And then the fluid is drained off at home, either by the district nurse or the patient and their relatives can do it. And it's a really good way of relieving breathlessness without people having to come into hospital.
But like I say, it also has its implications on living a relatively normal life.
That's right. It does. Some people really like it, but some people find that it's a constant reminder of the fact that they've got lung cancer. Some people may find drainage painful, or they may find it's inconvenient to have to wait for the district nurse to come in. So there certainly are disadvantages to it. But saying that, it's not necessarily in for the rest of your life. In a lot of people, it comes out after a couple of months.
And did you ever experience anything like this?
I really didn't, no. My cancer had travelled to my chest wall, but I guess I was lucky that I didn't experience this at all. So I had lots of other symptoms that mainly caused by my chemotherapy side effects, but I never had pleural effusion. So I count myself very lucky because it sounds scary, and the constant, you're in hospital so often, the constant going to hospital to have it drained off. I could see the attraction of having the pipe put in on a more permanent basis.
Chest drain.
It's a lot to cope with going through symptoms and going through chemotherapy and maybe radiotherapy and maybe immunotherapy as well. That's a lot to cope with. And if 40% of people get this, it's amazing that we don't talk about it more. Isn't it?
It is.
That's right.
Yeah. But you are talking about it because obviously this study is leading the way with it. I'm going to say the red score, and you're going to explain what that means.
That's right. So what we did in the repeat study is we included 241 people who had advanced cancer and pleural effusions. So about a third of those had lung cancer. There were also people with other cancers such as breast cancer and mesothelioma. And they came from 10 hospitals around the UK. And we divided them into two groups. So one group of 180 people was a discovery group. And we used those to identify variables that we could use to predict how long it would take for them to have another pleural fluid drainage. And then we used the validation group to confirm that these variables worked in another group. And what we found could predict how quickly people would need another drainage were how fast they were breathing, so their respiratory rate, how much fluid there was around the lung, so the effusion size, which we measured with ultrasound, and how breathless they felt, which we measured using a 0 to 10 scale. And we combine those into the red score. So red stands for respiratory rate, effusion size, and dyspnea or breathlessness. And what we found is that people with a high red score were likely to need another drainage within 2 weeks. If they had a medium score, they were likely to need another drainage in 2 to 6 weeks. And if they had a low red score, then it was likely to be more than 6 weeks, or they wouldn't need another drainage at all.
That was absolutely amazing that those statistics carried through from your test group to the other group to measure up, and that kind of carries through the whole way. I find that amazing. You can measure that in so many different individuals and get a similar reading from those people. How's that made a difference to the way that you treat people, or the way that your patients feel about coming in? And are they more prepared? What's that translated into?
So we are now using the red score in our patients in our hospital and in other hospitals around the country. And what we can use it is to inform patients about when the fluid's likely to come back, and then we can make a plan with them. So in patients who've got a high score, we tell them that their fluid's likely to come back quickly. We talk about the different options with them, decide together what's the best course for them, and then making a date in the next week or so for them to come in and have something definitive to manage the procedure and to manage their fluid. Yeah. In patients who've got a medium score, again, we talk about what the options are available to them and give them our phone number so they can call us up once they start to get breathless again, and then we can make another appointment in order to do something to manage the fluid. And actually, the people with the low score, if their fluid is only kind of come back every 6 weeks or even less than that, they may just want to come up and have it drained off as and when it builds up, rather than having something like a permanent drain put in. So it's really helpful information for patients and us to talk about and make a decision together about what's the best treatment for them.
That's really interesting. And does it make them feel, have you had feedback that it gives them reassurance that they are being looked after better because you can with them? I know I'd feel like that. I always like a plan, and I found it very hard to give over, like my control freakness was really hard to kind of just give myself up to the doctors, but having a plan and being able to follow it was my way of coping as well, knew where I was going to be. So I imagine that's really helped patients in planning and understanding what their disease is looking like.
Yes, I think it's really empowering for them as well to know what to expect and to actually have a date when they know they're going to come up and have their fluids sorted out. And it also gives them time to think about what they want to have and make the decision that's right for them, rather than suddenly getting breathless and not knowing what to do.
That would make me panic, because I would be really concerned on how quickly I could get an appointment when I get to that stage. So the fact that these people who are on the high scale of red, knowing they've got an appointment booked in, must be really, must give them a lot of
peace of mind.
Yeah, peace of mind. It definitely would for me. So that's really interesting.
That's what I think. So, you know, we talk a lot about, at Roy Castle, we talk a lot about helping patients advocate for themselves and be involved in their treatment plans, you know, be involved in their diagnosis as well. And you use the word empowerment, Eleanor, and I think that's a really, really important point, because when you're diagnosed with lung cancer, and Mandy, you can attest to this, is so much is out of your control, and you're entering into the unknown. And you have to give yourself over to doctors to manage your care to a certain extent. And then as the situation starts to settle and you start to not come to terms with it, but you know, you start to find your new normal, I think we use a lot. It's important to be able to focus on what you can control, and this study is helping people to do that.
Get help managing symptoms and side effects of lung cancer or treatment with our helpful guide. Download or order a copy of our Managing Lung Cancer Symptoms booklet by visiting roycastle.org/information.
And also, you know, you talked about being able to plan, because again, particularly with people with later stage disease, when you're living in between, you know, your 3-month scans, you want to plan, you want to do as much in that time as you possibly can. But if all of a sudden you have to factor in, oh, what if the fluid builds back up, and what if I get breathless again? But having that plan and that structure in place, it also gives you a bit more freedom again. It gives you the opportunity to go for lunch with friends, or, you know, take your grandchildren out, or whatever it may be. You can work around that new schedule, that new normal again.
I definitely agree with that. It's just nice to have a plan when you're going through treatment and you don't know what's coming next. And of course, lung cancer gets bad press and has been, you know, up to 5 years ago, pretty badly funded in terms of research. So the minute I was diagnosed 9 years ago, and the minute I heard that lung cancer diagnosis, I thought, that's it, I'm gone. You can't live without lungs, so therefore I'm gone. And here I am 9 years later. I was stage 3, but I'm still here because I gave myself over to the medical team. But you need a bit of hope at that point, and a little bit of a way of taking a little bit of control. So I feel that if I'd have had that and known that I had my regular appointments in and didn't have to scramble around for appointments, that would have given me a little bit of, like you say, peace of mind and, control back. So that's really interesting. I bet it makes a massive difference to these patients. It's really
something as symptoms go, I think getting breathless, being out, not, you know, struggling to catch your breath, I think that's probably one of the scariest. You know, not being able to take in enough oxygen is a very frightening place to be in. Like you said, Mandy, then causes extra panic, which makes you then more breathless. And I think it's one of those symptoms that you do associate with lung cancer, and, you know, struggling to breathe. And the fact that we're now, again, shows another advance in how much incredible work is going on that we're going to be able to manage this a lot better than we have done previously is just another step forward and another sign of hopeful things to come.
Yeah. It feels like we're at a stage where we're understanding the disease a bit more, and we're preempting what might happen and putting steps in place. And that's really good to hear, because a lung cancer diagnosis is devastating at whatever stage you're at, because we all associate it with what used to happen 20 years ago, where we know what the survival rates were. So to hear that there's all these great things in place certainly would give me hope if I was ever in that situation again. So yeah, really fascinating.
Yeah, it's been a really interesting research to do, and I really hope that it will be used and it will benefit people, because some of our findings weren't just about predicting when the fluid will come back. We also looked at what happened to people with these different scores. So what we found was that the people who had a high red score were actually much more likely to be admitted to hospital as an emergency with breathlessness. Yep. They tended to have recurrent drainages rather than having a definitive procedure. And I think that's because their clinicians didn't explain to them that the fluid was likely to come back and talk to them about what the procedures, what options were available to them. But most importantly, these people with a high red score were less likely to start new anti-cancer treatment. And I think that's because they were coming in and out of hospital, and we weren't managing their breathlessness properly. And so they weren't well enough to start treatment for their cancer. And so I think this is a real opportunity to improve care for this group of people and relieve their breathlessness and potentially help more of them start treatment for their lung cancer.
That's huge. And also, I think, as you were talking there, yes, people aren't necessarily well enough, but also if they're really struggling with breathlessness as a symptom, and you start to then question your quality of life, when you come to make a decision about treatment, sometimes, quality over quantity, or, people may think, I haven't got it in me to do more treatment because, I'm struggling to breathe at the moment. So, it's only going to get worse. And all of a sudden it gets very, very dark and very, very negative. This research it's for want of a better pun, breathing new life into options for people.
It's almost normalizing something that I'd never heard about. Like, this might happen to you, and if it happens, we have a plan. So it's not all of a sudden halfway through treatment, you're breathless and you don't know why, and you assume the tumour has grown, and then you go into an absolute spiral of negativity. Trying to get a hospital appointment, doctor's appointment, whatever it might be. I can imagine how stressful that must be. Whereas if you're told about it up front, that this might happen. I was never told about this. I've never heard of it before. Honestly, I've never heard of it before. So to be told up front that this might happen and these are the things to look out for and this is what we do, would be just another piece of the jigsaw that you can put in a box and say, well, if that happens, I know what I'm going to do with that.
That's looked after. I don't need to worry about it.
Yeah, you won't be shocked by it. It's like, oh, this is happening.
Yeah.
Really interesting.
Thanks to research and advances in treatment, more and more people are living well for longer with all forms of lung cancer. Read their incredible stories on our website, roycastle.org, and get in touch to share yours.
Eleanor, I'm keen to kind of understand a little bit more about you and your kind of background and how you got into this area, because as Mandy mentioned before, lung cancer hasn't had as much attention historically as other forms of the disease. What led you into kind of respiratory conditions and lung cancer research?
So when I was doing my training as a doctor, I did my first attachment in a respiratory department, and it was a really friendly department. And I suspect one of the things that attracted me to it was that every Wednesday the department got together and had lunch together and all talked about some research or audit And it was a really sociable way to improve the care that we were giving patients. And that really inspired me to go into respiratory medicine, but also to get into research. And so I carried on in that department, which was a department where they were doing a lot of innovative research into pleural disease. And actually, for my PhD, I ran a randomized trial which was looking at people with lung cancer and pleural effusions. And we were looking at the standard treatment at that time, which was bringing people into hospital for a chest drain and then putting talc into their chest to try and stick the lung to the chest wall, and comparing that with these indwelling pleural catheters, which are the drains which were used at home. And at that time, when I was doing my PhD, it was a really new treatment. And we compared the two treatments to see which was more effective at relieving people's breathlessness. And what we found was actually they were both effective treatments to help breathlessness, but they were very different in the experience for the patient. So the traditional treatment meant people had to come into hospital for maybe 4 or 5 days. Putting the talc into the chest is actually quite painful, and it didn't work in everyone. So it worked for about 3 out of 4 people. But it did mean that they could go into hospital, get things sorted out, and then go home without a tube. The indwelling pleural catheters were really good for people who didn't want to come into hospital, and it was a really good way of helping their breathing, but it did mean people had the ongoing bother of draining the fluid at home, and sometimes they do get infected, and that can be a serious problem to deal with.
Yeah, I can imagine. It's a really interesting subject about something I didn't know was a problem, but it clearly is. For 40% of people, which is a lot. And it's something that you're really helping them come to terms with and having a structured way of dealing with it. Really, really good.
And it's lovely to see when you talked about how you started off and, your PhD and your entry into the respiratory team. You just lit up when you started talking about it. You can see that there's such passion there to change for the better and find solutions for people living with lung cancer. But alongside the research, you're also a consultant respiratory physician as well. Tell us a little bit about kind of your day-to-day work and how you're interacting with people with lung cancer.
So I run a pleural clinic, so I see a lot of people who have pleural effusions, and part of my work is to try and diagnose the cause. So as Mandy said, they can often be due to infection, but a lot of them we see are due to lung cancer or other cancers such as breast cancer or mesothelioma. And so I'll be trying to make a diagnosis and trying to manage the fluid. But we also see lots of other patients with much earlier lung cancer. And so as part of that, I work with the surgeons and the oncologists to make a diagnosis and decide what the best treatment is for people.
So people come to you with a pleural effusion, but not knowing they have lung cancer. So you make the initial discovery and initial diagnosis alongside your oncologist colleague. So it's another way of diagnosing lung cancer, which again I'd never really heard of it being done that way. Because I didn't know about pleural effusion. It makes a lot of sense if you're in that situation that it's looked into properly, rather than someone shrugging and saying it's just an infection, it will take these antibiotics and it will clear up. So that's really interesting.
So is that what pleurisy is then, that infection?
Yeah, so pleurisy means pain in the pleura or inflammation of the pleura, and it often causes pain when you take a deep breath in. And one of the common causes is pleural infection, but it can be due to inflammation or something like cancer.
That's really interesting. And just by complete coincidence, I was chatting to a patient today who fortunately was diagnosed early, but was initially diagnosed with pleurisy, and that was the kind of part of his diagnostic journey as well. And again, I think, I obviously work at Roy Castle. I'm not a medic. I hear these words and I hear these phrases and I kind of presume I know what they mean and what they are. And then I speak to someone like you, Eleanor, who clearly knows so much and is so knowledgeable and so passionate. And all of a sudden the little penny drops. It's like, oh, hang on, pleural effusion, pleurisy. Yeah, right, it's all starting to come together.
I'm in the same place. And also for someone who's had lung cancer, to know that there are other ways of diagnosing it. And obviously I didn't have that symptom, but people might have that symptom. And obviously you could go and get some antibiotics. How is pleurisy treated? Is it with antibiotics?
So pleurisy is really a symptom rather than a diagnosis.
Yeah.
So it would depend on the underlying cause. But if the fluid around the lung is infected, that is quite a serious condition. And so we need to drain it off as well as give people antibiotic treatment.
Yeah, I thought pleurisy was nothing to do with lung cancer, but it very well could be. So I found it fascinating. I really do.
Yeah, and I think if people are getting chest pain that's unexplained or breathlessness, then it's really important that they go see their GP and get further investigations.
Yeah, absolutely. And can pleurisy be seen on a chest X-ray? Can you see the fluid around the lung if you have a chest X-ray?
Yes.
Not nearly detail, but can you be able to see it and then take it further?
So that's one of the commonest ways that we pick it up. So often people will go to see their GP and say they're breathless, and the GP will organise a chest X-ray. And we've actually got a pathway in our hospital where if our radiographers see a pleural effusion on chest X-ray, they can phone us up directly and send the person straight down to us so that we can prevent any delays, drain the fluid off there and then, and get investigations started.
That's fantastic. Yeah, it's all coming together, Rachel. All of a sudden, it's all come together in my head, and I didn't even know that was a route.
I knew we'd learn loads of stuff if we started this podcast, Mandy. I really have today. Mental capacity.
Today is definitely a school day. It's been so interesting.
Well, at the risk of a really stupid question now, which I'm prone to asking, can you prevent pleural effusions, or is it is there any kind of link to fitness or lifestyle? Does that increase a person's risk of developing pleural effusion?
So again, I think it depends on the underlying cause of the pleural effusion. So if it's caused by something like a cancer, then the important thing is to pick it up early and get it treated effectively, and that prevents it spreading to the outside of the lung. But as we were talking about, there are many different causes of pleurisy and pleural effusions. So, for example, it can be due to pneumonia and then can spread to the outside of the lung. And one really important way to prevent that is flossing your teeth. So having good dental hygiene is really important for preventing respiratory tract infections like pneumonia.
Mandy and I have gone silent because I've worked at Roy Castle nearly 10 years and I've never heard that. That's incredible.
It really is. Wow.
You wouldn't think that was how is that linked? That's incredible.
I suppose it's bacteria.
Well, Eleanor, you can come on again. You can tell us loads of stuff. This is great.
It's absolutely fascinating.
Amazing. Yeah. Just going back to the repeat study then. So you said it's being rolled out in your hospital, Norfolk and Norwich University Hospital. Is it available in other hospitals, or will it be? What are the ambitions or the next step of the project?
So the way to use the score is available online on the UK Pleural Society website. We're currently involved in translating the score into different languages so that it's accessible for people whose first language isn't English. And we're also trying to promote it across the country to clinicians and specialist nurses so that it is used more extensively. But I'd like to do more research to show that the red score can do more than just predict time to the next effusion, but actually help change the choices that patients make. So I think that people with a high score should actually be offered an immediate definitive procedure rather than having the fluid drained off and then having to come back. If we know the fluid's going to come back in a week or so, actually we should just do something there and then.
And what is that? What would that be? What would that entail?
So that would mean either putting in one of these indwelling pleural catheters or bringing them into hospital for a chest drain and pleurodesis.
Right. So how do you make that a reality? Is that the big question now?
Yes, so that's my next research study. So what I'd like to do is a study in people who have got cancer such as lung cancer. They come up with a pleural effusion, they've got a high red score, and we tell and they either have standard care that they have at the moment, which is a thoracocentesis, or they go straight for a definitive procedure. And I'd like to see whether having a definitive procedure immediately would mean they spend less time in hospital, they're less breathless, and they're more likely to get treatment for their cancer. And those would be really important outcomes for patients.
Absolutely. That's fascinating.
I feel like we need to mention that I'm presuming you work with a team, or is this a solo project?
No, so it's all part of a big team. So I'm really grateful to everyone else who's been involved. It was 10 hospitals around the UK, and there's research teams, specialist nurses, the clinicians, and also the patients who gave their time, answered questionnaires, came up for follow-up to help other people in the future. And so I'm really grateful to everyone who's been part of this project.
Absolutely. That's amazing.
I think that's a metaphor for how we take on lung cancer anyway, isn't it? It is about coming together for the greater good, and using everyone's skill set to find these new treatments, these new diagnostic techniques, these new procedures, anything that can make someone's life better. It's only a step forward in our eyes.
That's right. And I've seen the care for lung cancer being transformed over the 20 years that I've been working in this area. And it's incredible. And it comes from research and service improvement and patients' voice informing us what they want. And it's incredible to think about what changes are going to come in the next 20 years.
That's a really interesting point, and I'd love to pick your brain on that for a couple of minutes, actually, because you've been in the game for 20 years, you say.
Mm-hmm.
What have you seen? Cast your mind back to those 20 years and the state of lung cancer there compared to now, because it is huge, and there's there's so much momentum behind lung cancer at the moment that it's only going to keep improving.
Yes, there's been a huge change. I think we used to do far fewer CT scans and investigations, and so lung cancer was often picked up much later, and people's attitude to it, as you say, was very negative and nihilistic, and there was very few treatments, and that's completely changed. And now we're actively screening people, trying to identify lung cancer early so that it can be cured, but also looking at how we can prevent lung cancer by supporting people to stop smoking, cleaner air quality to reduce pollution, and all these things hopefully might put me out of a job one day. And
me. I would be in full support of that redundancy, to be perfectly honest. Probably a question to end on then. So what do you foresee, or what's your personal ambition for lung cancer in the future, other than curing it and putting us all out of a job?
So the people who I see with pleural effusions tend to have much more advanced cancer, and so it's not at a stage that often can be cured. And so what I would like for those people would be quicker diagnosis and more effective diagnosis, so that we could not just say you've got lung cancer, but also know exactly what treatment would be best for them. I'd like to be able to manage their fluid more effectively, so they don't have to have the bother of draining fluid at home or coming into hospital. So if there was some way that we could get the best of both worlds, that would be ideal. And to really improve people's quality of life and the enjoyment that they get out of life.
Well, we certainly share those ambitions.
Absolutely.
Eleanor, it's been absolutely enlightening. You know, Mandy and I, and I'm sure the people listening will have learnt so much. One final question is, if someone is suffering with pleural effusion, what is your advice to them?
I think that they need to get good support from their medical team. So most places, most hospitals will have specialist nurses, their lung cancer specialist nurses or their pleural specialist nurses. And those nurses are a great resource for talking about their options, helping them to plan ahead and helping to relieve those symptoms.
Don't suffer in silence.
Absolutely. We want to know about any problems early so that we can deal with them effectively. And what we don't want is people having a crisis in the middle of the night and coming up to ED.
And where can people find out more about your research? Has there been any publications?
And so it's been submitted to a journal, and hopefully I will hear back any day now. But there's also, it's been written about in mesothelioma matters, so the Mesothelioma UK newsletter, and also on the Cancer Research UK website.
Brilliant. That's great. Well, thank you again for joining us, and I'm sure people will have found that so interesting and above all so hopeful. Thank you.
Well, thank you for inviting me on. It was really nice to meet you both and have a chat.
It's a pleasure to meet you. Thank you.
You have been listening to Talk of Hope from Roycastle Lung Cancer Foundation. For support and advice about any of the topics covered in this podcast, visit roycastle.org. Talk of Hope is a fortnightly podcast with new episodes released every other Tuesday. Like and subscribe to make sure you never miss an episode.